So greetings to everyone joining us today. We are thrilled to have you here on our BMF case series. My name is Dr. Bat, a hematologist at the University of Texas Southwestern Medical Center. I'm delighted to lead our monthly BMF case series. Our aim to deepen our knowledge of rare hematological disorder by discussing the real patient cases. Typically, these sessions are scheduled for the first Monday of each month. I want to express my sincere gratitude to the dedicated BMF cases organizing team for their hard work in bringing together a community of hematologists and oncologists to facilitate these crucial discussions. Thank you for being part of this event, and we look forward to productive and enlightening session. So today, it's an honor to introduce Dr. Thomas Cortez as our esteemed guest speaker. He serves as the section head of hematology in the Division of Hematology Oncology at the Children's Hospital Los Angeles and holds position as professor of pediatrics and pathology at the University of Southern California Keck School of Medicine. Dr. Cortez specialized in sickle cell disease, thalassemia, disorders of neutrophils, and iron overload in both children and adults. From very early stage, he has been instrumental in developing MRI technology for measuring tissue iron in patients with hemoglobinopathies and iron overload. This technology has significantly advanced the clinical management of our iron overload and has contributed to validating concepts in the basic biochemistry of iron in humans. Now, let's attend some logistical matters. I kindly ask all participants to mute their microphones during our case discussion to minimize any background noise and potential disruptions. Please don't hesitate to share any question or comment in the chat box, and we will address them at the end of the presentation. Without further delay, let's give a warm welcome to Dr. Cortez as we kick off our session.
Well, good morning. It's really an honor to be invited to address this group and to talk about one of my favorite topics. You sent me a couple of interesting adult cases, and I'm guessing it wasn't just random the reason that you picked those two cases, because it fits very nicely into a discussion on the physiology of iron and how we can use this to, the physiology basically to guide how we treat patients. And so what I wanted to do before the cases were presented is to just review this iron physiology a little bit first, because this complicated diagram, which I'm going to walk through one step at a time, really guides me in how I think about managing cases and patients. So if you want to push the first slide, oh, too fast, back up. Yeah. So red blood cells either produced endogenously from the bone marrow or transfused are recycled through macrophages. I'm not going to talk about iron absorption through the gut here, but just the transfusion part of the story. And so the red cells go into the macros, they're phagocytosed by macrophages, and then they're degraded by hemoxygenase. And inside the macrophage, the iron is basically extracted, and it's extracted as ferrous iron. And one of the themes that's really important to understand when you think about iron overload and iron control is that iron exists in two states, Fe+2, which is highly toxic, and this is the enemy really in all cases of iron toxicity. We're trying to fight against iron toxicity. This is more important than whether there's iron actually loaded in the body, because when the iron is in the liver, it's in macrophages, it's in the RE system, it's converted into ferric iron, Fe+3, which is not toxic. So the Fe+2 inside the cell goes into ferritin, as the iron in the cell, ferrous iron inside the macrophages causes production of ferritin. So ferritin increases, and the ferritin heavy chain converts ferrous iron into ferric iron before it stores it. So it detoxifies the iron. The ferrous iron in the cell is either used in the mitochondria or is exported through ferroportin. So if you can hit the next slide. So ferroportin is the only known iron exporter. And the iron has to be in the +2 state in order to go through this channel. But it can't leave the channel until it's converted back into ferric iron so it can bind to transferrin. And that's accomplished by a copper-dependent protein oxidase called ceruloplasmin. So the iron leaves the macrophage, is converted to ferric iron and binds to transferrin. And again, the ferric iron bound to transferrin is not toxic. Next slide. So transferrin then binds to its receptor, and there's 2 transferrin receptors, but the main one that transports iron into all cells in the body is the transferrin receptor type 1. And it's they're on the liver, but they're on every cell of our body has transferrin receptor type 1. Not every cell in the body has TFR2. Next. So the critical part here is that TFR1 is regulated. If intracellular iron is high, you stop making TFR1. So you stop transporting iron. So the body has a normal mechanism to protect against iron overload. If you have too much intracellular iron, you stop making the receptor and you stop transporting iron. So technically, you shouldn't be able to become iron overloaded. Next slide, please. So normally, the iron is circulating bound to transferrin, and about 30% of the transferrin has iron on it. 70% is unbound. However, when you're transfusing somebody and you have excess iron loading, you exceed the ability of transferrin to bind the iron. And when the transferrin saturation gets up around 60 to 70%, then the iron starts circulating in the plasma in what's called non-transferrin bound iron. And this is really bound as iron citrate. And you can see in the upper right, I make this statement: when the transferrin saturation is greater than 60 to 80%, you have very high levels of circulating non-transferrin bound iron. This is pathologic. Normal people do not have circulating non-transferrin bound iron. And the critical part about this is, while NTBI is ferric iron, there's a pH-dependent equilibrium with ferrous iron. So if you have high NTBI, you also have high ferrous iron. And this is the source of the toxicity from iron. And so what we're trying to fight when we treat these patients is to get rid of the circulating NTBI. Now, next slide or next. So if you have circulating NTBI, then you have circulating ferrous iron. And the bad part about this is it's in the +2 state. It's highly reactive, but it can also enter through other transporters that are circled in red here. ZIP14 is a zinc transporter, DMT1, the divalent metal transporter, and the L-type calcium channels in the heart. All of those are not designed to transport iron, but they do in the presence of ferrous iron, and it's unregulated. So even though you may have high iron in the heart or the pancreas or the pituitary gland, you still send iron into those organs if the circulating NTBI is elevated. So this is what we are fighting with iron overload, and we can't see that clinically. The transferrin saturation is a poor man's measure of circulating NTBI, but you can't really see. That's the only test we have. The MRI is measuring ferric iron already in the protected state. Next slide, please. So normally, we absorb 2 milligrams of iron in our diet. and we recycle 25 milligrams of iron in our bone marrow. So the bone marrow is the major utilizer of iron. Next slide, please. So if the bone marrow is not working, and this is a critical point, if the bone marrow is if you have ineffective erythropoiesis or you have no erythropoiesis, then the circulating NTBI goes through the roof. It gets very high. So it's bone marrow activity that regulates, into a large part, how much circulating toxic iron is there. And we see this very clearly in different, hemolytic diseases like sickle cell disease. You can have high liver iron and you have no circulating toxic iron because the marrow activity is increased. In aplastic anemia, you have tons of circulating toxic iron because you have no bone marrow activity. So much more toxicity if the bone marrow is ineffective or not working at all. Next slide, please. So pathologic iron in the heart or in the pancreas, this indicates that there has been exposure to circulating toxic iron. And the really other important thing is when there is circulating chelator, you immediately drop the circulating non-transferrin bound iron to 0. You may still have stored iron in different organs, but if there's chelator circulating, it decreases, it brings the NTBI down to 0 and it protects against the toxicity. So I wanted you to think about those points as you listen to the presentation of the two cases you're going to present, because they demonstrate two different states of iron metabolism and also different effects on organ toxicity.
Okay, so maybe we should start with the first case. This is a 43-year-old Hispanic male. He has an end-stage renal disease since 2016. He was treated with IV iron and erythropoietin, and he was presented with refractory normocytic anemia at around 2018. His haptoglobin was normal. He had unremarkable nutritional panel, and his EPO level was 114. His HIV Hep C was unremarkable. His myeloma MGUS workup was unremarkable. His PTH was less than 300. His retic count was 3%. And despite the maximum dose EPO, he became a biweekly transfusion dependent at around 2018 to keep hemoglobin above 6 grams. And 2019, ferritin was 2,500. MRI abdomen showed a severe splenic and moderate to severe hepatic iron overload with the transferrin saturation of 40% at that time. LIC was not documented. Cardiac MRI did not show any iron overload. And then he started the iron chelation, but interrupted many times due to LFT elevations with ALT 130 and AST of 150. So the diagnosis of severe iron overload was made. So the bone marrow biopsy in 2019, he had multiple bone marrow biopsies. 2019 was normal cellular with increased iron storage. The repeat bone marrow biopsy in 2021 showed the normal cellular marrow again, and iron studies performed and showed markedly increased storage iron. There was no ring steroblast. Cytogenetics or the MDS fish panel was all unremarkable. NGS was unremarkable at that time. And then flow cytometry was not did not show anything abnormal. The blood work or imaging, the MRI, repeat MRI showed the 6.5 milligram per gram dry tissue iron overload concentration. He was started the Jaduna with slightly high LFT elevation, and his hemoglobin gradually improved to 9 grams per deciliter while on iron chelation without any transfusion support. So I will leave up to you, Dr. Kodas, to go over the questions.
Okay, well, can we go back a couple of slides just for a second? So a couple of points here in the presentation. This patient's bone marrow is not dead. He's reticuling. So he is making red cells. Now we know in renal failure that there's decreased marrow activity. It's not normal, but nonetheless, his marrow is not dead. The other thing to point out is his transferrin saturation was 40%. So that's not very elevated. So we can use transferrin saturation sort of as a poor man's measure of circulating toxic iron species. And so that just based on that one single number. Now, transferrin sat's not the greatest test in the world to follow iron with, because it has a very short half-life. It's kind of like a random glucose. It goes up and down really quickly, but nonetheless, because he has an active marrow and his transferrin saturation isn't very elevated, and he had no cardiac iron, so there wasn't any loading into the heart. And maybe can we go back just again to the previous slide for a second? The other point to make here is the last statement here is that his JADNU was interrupted many times due to liver elevation, but the AST and ALT that you're showing us here is only 130 to 150. So iron overload causes elevation in the transaminases. And it can cause AST and ALT, even in the 200 to 250 range. Now, if your liver iron concentration is 6, so the liver iron concentration, I think I show this in a subsequent slide, that's not horrible. It's high. Normal is 1.5, but it's not horrible. So this degree of elevation of the transaminases could be from the iron. The other probably is from the iron. The other thing to note is that deferocerox or JADNU, this doesn't really cause liver toxicity very much. About 5% of patients have chemical hepatitis from JADNU. And when that happens, or from deferocerox, when that happens, the transaminases are in the thousands. I mean, it's really a significant response. Transaminases in 150 range, this doesn't even get my heart rate up. And so I would have continued chelating, certainly follow the transaminases. But what you'll see is as the liver iron comes down, the transaminases will also come down. We do see transient rises in the transaminases due to intercurrent viruses, EBV stuff, things like, in pediatrics, of course, we blame everything on viruses. I don't know what you blame it on in internal medicine, but you'll see transient elevations in those. So I'm not saying you don't watch it, but one of the problems is that the transaminases will go up to 300 and you stop the JADNU and they come back down again, and then you say, aha, it's the JADNU. Well, this could be true and unrelated. Probably is not the JADNU. Probably there was some intercurrent other thing that was causing the transaminase elevation. All right, next slide. So again, you have marrow activity here. You have decent cellularity, you have moderate liver iron concentration. So let's go to the next slide. So I'm going to just touch base on a couple of these questions and then present some data, and then we'll come back to this slide. But how often do instances of iatrogenic overload come to our attention? Well, it depends on how often you look. I'll show you a slide. There's a linear relationship between liver iron concentration and the number of transfusions that you get. And so, basically 1.08 times their number of cc's per kilogram of packed cells will tell you what your LIC is. So humans have no way to get rid of iron. There's no you lose about 2 milligrams of iron a day through sloughing of the skin, and women a little bit more through their menstrual periods. But generally speaking, there's no way to excrete it. So it keeps going up unless you chelate. Can we elaborate on evidence indicating iron overload suppresses the marrow? There's no question that this is the case, and I've given you a quotation for one of the earliest data from the adult literature paper by Jensen, where he shows that good chelation in MDS and myelodysplastic syndrome, low risk. So this is refractory anemia with ring sideroblasts. you can see 71% of the time transfusion requirements decrease. 45% of the time the patients become transfusion independent. And also their white counts and platelets improve. Now, I don't see a lot of adult MDS, but I have a handful of them that the adult guys ask me to help manage their iron overload. And I've seen this just in the small number I've seen with normalization of their counts and transfusion independence. It depends on what the gene is causing the MDS too, but that's a whole other story. So absolutely, this is the case. There's all kinds of anecdotal data showing that chelation can cause of severely iron overloaded patients can cause reversal of the bone marrow failure. And there's a number of mechanisms that talk about that. What about severity of iron overload? Again, I put a little table here. Normal is 1.5, liver iron concentration of 1.5. So that's what we consider to be acceptable. We don't usually start chelation unless the liver iron concentration is around 3, especially with JADNU, because chelating at low liver iron with JADNU really increases the likelihood of toxicity of the JADNU. And then over 20 milligrams is pretty bad. The highest you can measure by MRI is about 40. The measurement becomes nonlinear after that. Normal T2 star is greater than 30. That means no pathologic iron, but 20 used to be considered to be normal. It really sort of is normal. But those are the numbers. Less than 10 milliseconds is dangerous, but the most critical thing is a low cardiac T2 star with cardiac dysfunction. This is really an emergency. The other thing that's really, really, really important to understand: heart failure and arrhythmia due to iron overload is reversible 100% of the time. And the cardiologists don't know that. So they'll see a low left ventricular ejection fraction and they'll think there's nothing you can do about it. And that's not true. I've seen patients in floored heart failure, unable to walk from one side of the room to the other with an ejection fraction of 15, that we totally reversed with chelation alone. And at the end of 3 or 4 months, their cardiac T2 star was still around 6, but their ejection fraction was back to 70%. So if the heart failure is due to iron overload, it is 100% reversible with good chelation. And I didn't put the reference here, but there is a paper by Dudley Pennell, the senior author John Wood in Circulation from 2015 or 2013, which is the American Heart Association Recommendations for the Management of Iron Cardiomyopathy. And you should have a copy of that someplace, especially with reference to the second patient you're going to present here. All right, next slide, please. So this is just to make the point that we chelate patients to protect them from toxicity. And what you see on the right in the red is non-transferrin bound iron. That's the iron I talked about that's toxic. What you see in blue is desferrioxamine levels. And you can see that when the desferrioxamine, which has a very short half-life, only 30 minutes, so it has to be given by continuous infusion. And by the way, some people give this with transfusion, and that's the only time they give it. That's a total waste of time. Complete waste of time, because for only 30 minutes or 2 hours of desferrol while you're transfusing somebody, you're not taking out any. You're taking out a small amount. They need to have, for desferrol with a short half-life, continuously infused either sub-Q or intravenously for 12 hours a day. But the critical point here is you see the NTBI level drops to 0 as long as the chelator is circulating. That means there's no iron going into the endocrine organs. There's no iron going into the heart. So, I mean, people have had tachyventricular arrhythmia secondary to iron. You turn on the desferrol, the arrhythmias go away. The nurse stops the desferrol to change the IV set for 30 minutes. The arrhythmia comes back. You turn the desferrol back on, the arrhythmia goes away. It's the presence of the circulating ferrous iron that causes the danger for this, and it changes very, very quickly. So that means we adjust chelators to maintain circulating chelators 24/7. The same pattern you see here on the right is true for all chelators. The shape of the curve depends upon the shape of the blood levels of the drug you're using. So the first goal is to protect from iron toxicity, to bind the circulating ferrous iron up in chelators so it can't be toxic. And then the second goal is to remove it from the body. We want to keep the circulating labile plasma iron, that's another word for circulating ferrous iron, to keep that at 0 at all times. Next slide. This is the relationship between total body iron and liver iron concentration. You can see it's very linear, correlation coefficient of 0.98. It doesn't get any better than that in biology, and the equation there tells you how to calculate the LIC based upon the body weight and the number of cc's of blood that you give the patient. So measuring the LIC is a very accurate measurement of the total body iron concentration, but it doesn't tell you anything about the iron in the heart, the pituitary gland, the pancreas. The volume and the mass of iron in the liver is very large compared to the volume of the heart and the volume of the pituitary, the volume of the pancreas. And so only a small percentage of the total iron in your body is in those other organs. Most of it's in the liver and in the bone marrow, but it's a linear correlation, liver iron concentration. And MRI is the best way to do it. The variability by biopsy is horrible. There's a 30% difference in iron concentration between the capsular edge of a biopsy specimen and the 2 centimeters in, 30% higher at the capsule than it is internally. The variance of iron in liver biopsy across a liver full of iron is 70%. The coefficient of variability for MRI is 5%. So we don't do biopsies for iron quantitation anymore. We certainly don't do bone marrow biopsies to measure iron. This is way out of date. It's not worth doing. Next slide, please. So commonly people measure ferritin. This is from a paper we published a number of years ago. You can see the relationship between liver iron concentration along the x-axis and ferritin along the y. The correlation coefficient here is 0.8. There is a very good correlation, but the variance is huge, as you can see. There you see somebody with a liver iron of 10 and a ferritin is as low as 1,000 and one as high as 8,000. So there is a correlation. It's easy to do when we check them, but you need to be, the variability is huge. And also the relationship between a liver iron concentration and ferritin depends upon the disease. You see the dark circles there are largely hemolytic anemias. You can see the slope is different than it is for thalassemia. So there's lots of sources of variability for ferritin. So it's a reasonable thing to use just to get an idea, but it is not the final answer by any stretch of the imagination. Inflammation also changes it. I've had a patient that got bacterial cholecystitis and her ferritin was 2,000. The day after she got the gallbladder infection, her ferritin was 50,000, 50,000. We treated her with antibiotics, and 5 days later, her ferritin was back down to 2,000. So inflammation is a major thing that affects ferritin levels. Next slide, please. Serial ferritins are helpful. Here you see in blue ferritin levels and in red over a number of years, the MRI levels. What you can see is there was good tracking for the first several years. And then later on, as her liver iron concentration remained stable around 2, her ferritin went back up again. So 20% of the time, the change in ferritin does not accurately reflect the change in liver iron. So you really need to do both. Next slide, please. So you ask about chelators. I put this just in there for your reference. I'm not going to go over, this thing in its entirety, but a few major points. first of all, I put some of the good stuff is in the comments, down in the below. But the first thing is we really want circulating chelator 24/7. If you are off chelator, for example, with this Deferocerox, it has people say, great, you can give it once a day. Well, 30% of patients are hyper absorbers or hyper metabolizers of Deferocerox, and it's all gone in 12 hours. So that means the second half of the day, your circulating NTBI levels are high, and you're loading your heart, you're loading your endocrine organs. There's a really cool paper where they looked at ferritin levels that were steady in a group of patients, and all they did was change the Deferocerox from once daily dosing to dividing it BID, and the ferritin started coming down. That's because the second half of the day, you're not removing the circulating non-transferrin bound iron, and it's going back up and into the macrophages and stimulating ferritin production. And so we've seen that a number of times. Our standard way to use Deferocerox is to divide the dose BID in all patients. The usual dosing is there. For Deferocerox, renal toxicity is a huge problem. In my experience, especially with internists, is they just slap patients on this and they forget about it. That you will not control people's iron that way. You need to adjust the dose, follow the liver iron, and make sure it gets down. But you need to follow creatinine every time, and you need to do urine protein creatinine ratios. Your creatinine can be stable, and you can be dumping protein like crazy. I just had a 30-year-old woman I've been taught, who actually is an oncology nurse practitioner with thalassemia. And for the last several years, I keep saying, show me your urine, show me your urine. Your creatinine is stable. She finally got a urine, and she was dumping protein like crazy. They biopsied her liver or her kidneys, and she had all kinds of kidney damage. Now, I don't know what percentage of patients on Deferocerox get this. It's probably only 5%, but since we have a really large population we follow here, we do see it. And people are going to be on this for life. So especially if they have thalassemia. And so we don't want to trade their thalassemia for dialysis when they're 50 years old because of that. So follow the urine protein very carefully. If the urine protein creatinine ratio is more than 2.5 times normal, on repeated measurements, that's a funky kind of a measurement. It depends on how much hydration they've had and stuff. And so we don't respond to single abnormal measures. But if 2 or 3 times the urine protein creatinine ratio is high, you need to modify the dose. The other thing is, if there's a 30% increase in the creatinine, you need to modify the dose. And this is another problem I see, especially dealing with internal medicine people. They'll look at the creatinine and they'll say, oh, it's fine. Your creatinine is 0.9. So don't worry about it. Well, if you started your Deferocerox when the creatinine is 0.6 and now it's 0.9, that's a 30% reduction in your GFR. And that Deferocerox dose needs to be modified. You need to stop it, let things correct, restart it. Otherwise, they're going to go into renal failure. And there have been deaths from renal Fanconi syndrome in patients on Deferocerox. This is a good drug. It's convenient, but I really worry about long-term use and this renal toxicity. Deferoprone is a superb drug. It's the most protective against oxidant damage. The dose is 100 milligrams per kilogram, not 75 that it says on the package insert. At 100 milligrams per kilogram per day divided, it is equally effective to other medications in removing total body iron. The big problem is in 1.5% of the patients, they get agranulocytosis. There have been deaths due to that. This is completely not predictable. You can have a normal CBC on Monday and have severe agran on Tuesday. It is not dose dependent. It is idiosyncratic. But if you have repeated severe agran, then you have to stop the medication. The most important thing is the patients need to know if they have a fever, mouth sores, or anything like that. They need to stop the drug. They need to go immediately to the emergency room and tell the doctors there that they are on a drug like chemotherapy that causes fever and neutropenia, and they need to be treated. That's what's important, not following the CBCs. And since that has been implemented, there have been no deaths from this medication. It's very safe. It does cause rise in your AST, ALT very commonly after starting it. You can go up, 30, 40% over a few months, and then it comes back down again. Desferal is a great drug. It does have problems with, hearing loss, and you can, if you overkeep, by the way, with the ferroprone, it can be used in the face of renal failure. It is not nephrotoxic. It is pretty well tolerated. There are other side effects, but you are not at higher risk at low iron concentration. That is not true of JADNU. If your total body liver iron, if your liver iron is 3, you need to really watch the toxicity very, very carefully. The incidence of renal toxicity is higher. GI bleeding is also, especially in adults, is a problem with the ferrocirox. So at low iron concentrations, you need to watch very carefully. So I think I'll leave it there. You can ask questions later on. We could talk for quite a while about the details about how to chelate. So I think we covered everything. I think number 7, which context should use of iron chelators be avoided or approached cautiously? I think I talked about that. The flip side of that is if you have heart failure, cardiac arrhythmias, you really want to have the patient on deferoprone. It is no question the best drug for cardiac problems. So I'll stop there for a second and see if there's any other questions about any of that.
Well, we can get the question at the end, or the question I have is, do you usually start, which agent do you start with? Do you usually start with deferoxamine if you're cirrhotic, or you prefer the deferoprone because it's safer?
Well, they're all safe if you monitor them. We usually start with the deferoxamine because it's convenient, and it's pretty well tolerated. There's some exceptions to that, but for the most part, that's where we start, and then we add. You can mix and match these. By the way, I didn't talk about that. But, you can use, for example, we commonly will put patients on JADNU, and then if they're spilling a little bit of protein or something, or we're worried about the kidneys, we'll use a lower dose of that and add deferoprone. So they're on 2 chelators. And then since we use the JADNU twice a day, and there's a twice-a-day version of deferoprone, they take them BID, and we can utilize the fact that deferoprone is not nephrotoxic. So really what you need to do, the other point I did put it, I put it in red in the comments. All of these chelators have the same problems, and that is that they don't work if you don't take them. And so it's really critical to adjust this program so that the patient will take the drug. And so the nurse practitioner who works with me is really a master at that. And you want to regulate 1 or 2. We occasionally have used all 3, but these to try to minimize the toxicity and to make it more convenient for the patient or make it so it's palatable. But normally we start with JADNU, and then often we'll add the deferoprone as a second agent if it's not being effective. If the drug is not, it takes a while to know, by the way. It takes months and months and months and months to know whether this stuff is working. And again, you need to follow the ferritin and the liver iron concentration. You have to be patient. The other thing is, by the way, that's also important is it takes months to years to develop severe organ toxicity. So, people will get nuts because their ferritin goes up over the period of a few months. That's a few months high iron isn't going to cause problems. Iron damage is how much iron is there and how long is it there. And so I've had thalassemia patients whose liver irons were 1.5. Many of our patients in my practice have no extra total body iron. and got pregnant. And we stopped her chelation. She had 2 babies, went back. Her liver iron was 35 after the second child. We put her back on chelation. She's fine. She hardly got any cardiac iron at all during that whole period of time. So the duration of time to get organ damage, by that I mean organ dysfunction, is measured in years. So you have time to regulate combinations of these medications to suit the patient's lifestyle and to optimize it and get the iron under control, usually, except if you have high cardiac iron with dysfunction. That is a different story. That's more or less an emergent, but everything else you have a little bit of time. All right.
Okay, we can move to the second case. This is a 66-year-old Caucasian male and was diagnosed with pure red cell aplasia at around 2010, has been refractory to most IST treatment. He has been a transfusion dependent in the last 5 years to keep the hemoglobin above 9. Ferritin was noted for 6,000. MR liver showed that he has an iron overload with LIC of 23 milligram per gram. And his MRI cardiac also showed T2 value of 9 millisecond with the 30% EF per his echocardiogram. So his iron overload, severe iron overload diagnosis was made. His biopsy showed he has a consistent pure red cell with iron storage with otherwise unremarkable cytopenia. And he started the JADNU, profoundly experienced GI bleeding 6 months later. He was switched to deferopiron and developed agranulocytosis a year later. And he's currently on defruxamine sub-Q and tolerates well. So the question is, I will leave up to Dr. Cortes for questions.
All right. Well, let's first go back to the case presentation again. So a couple of points here. First of all, again, yes, you had corrected previous slides. So here again, you say MR elastography. Elastography doesn't measure iron, just FYI. MR does, but not elastography. So 23 is a pretty high liver iron concentration in the first place. I don't see a transferrin saturation here, but it probably was high. The transferrin saturation probably was 80% or so. But here you have significant iron cardiomyopathy with a T2 star of 9 milliseconds. So he has a ton of iron in his heart. So this makes the point from my first slide. He has no bone marrow activity, no utilization of the recycled iron because he has pure red cell aplasia, and he has substantial cardiac iron overload. So the reason for that is the lack of, he has no marrow activity, and all of that circulating toxic iron is going into his heart and his pancreas. So this guy, hopefully you're checking his testosterone and his thyroid studies and his TSH. I can guarantee that his pancreas is filled with iron. I can guarantee his pituitary gland is chock full of iron. And so he probably has some degree of panhypopit. His thyroid functions are probably abnormal, which is important for cardiac function. Also, the other thing that's true of patients that he also has left ventricular dysfunction. So this guy is in trouble, big trouble because of that. And if that left ventricular, and there's a couple of really important points. First of all, where are you keeping his hemoglobin level? Because this guy should be maintained at a hemoglobin of 11 or 12. And this is one of the biggest problems I see in adult practices, especially with MDS. Low-risk MDS, the internists keep their hemoglobins around 7 or 8. And what is the reason that low-risk MDS patients die? It's heart failure. It's not malignant transformation. So prolonged exposure to anemia causes myocardial fibrosis and all kinds of problems. And the data from thalassemia is crystal clear on that. Patients with non-transfusion dependent thalassemia, their median survival is 55 years. If the ones that are transfused, their median survival is the same as the normal population. They have left ventricular dysfunction with no iron in their heart. So this guy's left ventricular dysfunction in part could be from chronic anemia. Now he also has iron. So if that low ejection fraction of 30% is from iron, that is 100% reversible. If you get his cardiac T2 star back into the normal range. Now I'm going to show you a slide on that in just a second. The other thing is that with severe iron overload like this, 40% of the patients have undetectable thiamine. They also have vitamin D deficiency. They have low ceruloplasmins. They have low carnitine. You know, severe thiamine deficiency, this gives you heart failure, right? You know, beriberi. We forget about that. So this patient needs to have his thiamine checked and needs to be on supplemental thiamine. He needs to be on supplemental carnitine because the iron deficiency induces substantial loss of those nutrients which are important for left ventricular function. Vitamin D also is important for left ventricular function. So it's not as important as thiamine and carnitine are. So those are additional things about this guy's management. And so I guess my question is, has his heart function improved at all, his ejection fraction with chelation?
Well, he just started the chelation because he just transferred his care from another institution. We just started iron chelation.
Okay, well, you need to follow, and so you guys weren't the ones that put him on Feraprox?
We are the one that was initiated iron chelation to begin with, yeah.
Yeah, but you said he had problems with Feraprox, right? With deferiprone?
He did have agranulocytosis with that before,
Right.
in the past, not recently, but we did
Okay.
notice that.
So you should revisit that and make sure it wasn't just a transient dip in his neutrophil count, because the other thing is there are other things that can cause granulocyte problems. What's his ceruloplasmin? Is his ceruloplasmin really low? That gives you neutropenia. What's his methylmalonic acid level? B12 levels aren't helpful. You can have a normal B12 and have a high methylmalonic acid. Does he have B12 deficiency? So you need to check his methylmalonic acid and his homocysteine and his ceruloplasmin. A low ceruloplasmin, a low ceruloplasmin, copper is really important for getting iron out. You can't release iron unless you have adequate ceruloplasmin. The copper level doesn't matter, the ceruloplasmin does. So if his ceruloplasmin is 10, you need to get it up. Low ceruloplasmin by itself causes a bone marrow picture indistinguishable from MDS, and it's correctable by feeding them copper. So there are other things to think about in this patient, and it causes pure red cell aplasia. I presume he was also worked up for a large granular lymphocyte disease, which can also cause pure red cell aplasia. So this is acquired pure red cell aplasia, and I guess I don't want to get off on that differential too far, but it's going to be really important to follow his cardiac function. The drug of choice for a T2 star like this with heart failure is deferiprone. So you need to revisit that. Did he really have agranulocytosis? Because if there's really a question, you could carefully try that again. It is the best drug for heart failure. But Desferal, as you're using, that will also work, as I'll show you in the next slide. But this guy is at great risk because he has cardiac dysfunction. And then if that ejection fraction is only due to iron, it is 100% reversible by getting his iron under control. Now, he's 66 years old. He could have the diastolic dysfunction. I don't know whether his left atrial size is big or not. He could have, diastolic dysfunction, which is seen associated with long-term chronic anemia. Again, patients with refractory anemia with ring sideroblasts, they die from heart failure because of chronic anemia, because people keep their hemoglobins at 7. I mean, this is becoming, in the thalassemia world, this is becoming crystal clear right now. There's very good, in fact, there's yet another paper I just sent out yesterday looking at this in thalassemia. Hopefully it will get accepted to Blood, which shows this, but there are other papers that show the same thing in non-transfusion dependent thalassemia. So yeah, so those are my comments there. You need to look at his thyroid function. You need to get the other thing that occurs with severe iron overload like this is adrenal insufficiency. So he needs an AM cortisol and an ACTH level to make sure he's not adrenal. With over 30% chance he's got adrenal insufficiency. And if he crashes and gets into trouble and he's adrenal insufficient, I mean, anybody with this much iron overload that got into trouble, I would just blast them with steroids and assume that they're adrenal insufficient. So again, I would highly recommend that you look up the papers, first author Pennell, last author Wood, in the Circulation, which is the American Heart Association recommendations for the management of iron cardiomyopathy, because this guy has it. The other thing is, I don't know what his blood pressure is like, but amlodipine blocks iron entry into the heart. It's a calcium channel blocker. So again, and by the way, we're happy to help you with this if you like. And the guy that my colleague here, John Wood, is a pediatric cardiologist, but he's one of the world's experts on iron and adult. Believe me, adult cardiologists really don't have any experience with iron cardiomyopathy. So you need to get that So anyway, so that's the story on this guy. Get his hemoglobin up to 12, really intensify his chelation. Why don't we go on to the next slide here? So, and I think there's some animation here. So if you hit the, yeah. So this is on deferoprone alone, what you're doing with this patient. This is a series of 10 or 15 patients that Anderson published a number of years ago. You see in baseline, their cardiac T2 star was 5, liver iron was only 9, and the ejection fraction is 52%. They started them on 24 hours a day, 7 days a week deferoprone, which is what I would do. I mean, desferol, which is what I would do with this guy. I would have him on 50 to 60 milligrams per kilogram per day. Make sure he's getting some vitamin C every day, not a ton, but some. 200 milligrams of vitamin C every day, because that releases the iron from storage so it can be chelated. And put him on 24/7 and follow his ejection fractions. And his ZEO patch. If he hasn't had a ZEO patch, he needs one of those. 40% of patients with a severe iron overload have intermittent atrial fibrillation. So you can see the cardiac T2 star, the liver iron, and the left ventricular ejection fraction. These patients were put on 24 hours a day, 7 days a week, intravenous ferroprone, 50 to 60 milligrams per kilogram per day. High dose doesn't buy you anything more. If you want to go up to 70, that's okay, but super high dose gets you into trouble, and it's not clear that it helps. Next slide. So now you see after 3 months, hardly any change in his T2 star. There's a little improvement, and that's more than it appears because that's a nonlinear scale. Next slide. But you see his ejection fraction is already normal, even though he has a ton of iron in his heart. So clearing the circulating non-transferrin bound iron by continuous infusion of chelator improved his ejection fraction. Or not his, this is a series of several patients. Next slide. Now, a year later, you see that the cardiac iron is still very high. Next slide. But you see his ejection fraction is now totally normal, and his liver iron is down to 2. So a couple of points here. Cardiac iron does not map with liver iron. The kinetics are different. Under full chelation, you can remove half of the iron in your liver in about 4 to 6 months. It's 13 to 15 months to remove half the iron from your heart under full chelation, which you see very clearly here. But the important thing you also see is that there is functional normalization with clearance of circulating non-transferrin bound iron. All right. Maybe go back to the, did we hit all the questions that you had?
I think the question is unanswered one was is there any other medication that is coming onto the market soon for iron chelation? And the L-Thrombopac question, the EPOC question.
Yeah, no, L-Thrombopac has some iron chelating abilities, and there's been a couple of papers out, but nobody really thinks that it's substantial. It's not worth playing with. If you wanted to see if it would help his pure red cell aplasia, that would be okay. I'm sure you've tried, you know, the usual immune therapy for that, but also look, the other thing, I don't know about you guys, but we're at the point now where when we get these bone marrow failure cases, the first thing that we do is get a focused exome. He could have a DBA gene. You know, I mean, there's a lot of interesting things you follow, and of course, in pediatrics, a lot of our stuff, you know, is genetic. But I'm trying to correct his pure red cell aplasia. That's a whole different story, because that will fix everything. Then he can use the iron, but that he's not using. But absolutely, the cardiac thing is a big issue, and chronic anemia is going to kill him. I had a 67-year-old guy that I follow that turned out to have MDS that we actually diagnosed. He also has a thalassemia mutation. I have 10 years of MRIs, normal function, no cardiac iron, but I couldn't get his internal medicine doctors to keep his hemoglobin over 7. And about a year ago, we got an MRI and his ejection fraction was 15%. Never had any iron in his heart. And we immediately got the transfusion levels. His hemoglobin is up to 11 and his ejection fraction is now 30. And I'm still hoping it's going to, and he was dramatically better. So chronic severe anemia, you can't provide oxygen, and you know, the heart has a huge oxygen demand, and you can't provide it. Then you get a myocardial fibrosis, which we're seeing. We're shooting gadolinium in these patients and measuring their extracellular volume fractions, and it's high. So keep this guy's hemoglobin high and get his iron completely controlled, and he'll be a hell of a lot better. And also check those vitamin levels, by the way. MMA, homocysteine, thiamine, carnitine, B12, or vitamin D.
Okay, great. No, this is very useful, Dr. Cortes. I mean, a different perspective helps for this bone marrow failure patient, because we usually aim on targeting the immune system by suppressing it, but we don't usually think about the iron toxicity part. We do think about it, but we don't really promptly addressing it. And this is what happened to this guy. He had this diagnosis. He has seen by many hematology experts in the world. I mean, but no one really addressed this iron chelation part. Anyway, but it is very, very interesting cases. Thank you, Dr. Cortes. Does anyone has any other question?